So from the morning, we had Dr. Nagarjuna who had spoke about the anatomy and the physiology of the larynx, and my guru Hariprasad sir who has spoken and tried to connective both the assessment and the treatment, as he mentioned that the very big piece of managing a persons with a voice problem is all about understanding the pathophysiology and what is going inside this vocal cord and the respiratory aspects. So I will be talking about this protocol of voice assessments, and then we have Jish who will be talking about the intervention of the voice. So in my talk, I will be talking about what is a voice and how does a voice disorders develop, and what is normal and abnormal voices, and how do we assess. So Hariprasad sir also actually tapped about these two aspects, but I will be just trying to brush up that. So this is a sound or this is a voice, right? So ultimately we're all deliver maybe in the singing or maybe in the speaking. So this is ultimately the waveform which will be coming out of it. And they say like the voice has so much of power where you can also break the stones. And here I just found this GIF where he is making a sound and the glass is breaking. I don't know how much it is real, but yes. So the voice has a power. And as you know, this, yeah. So voice has an emotion, right? So why do we all, we have to speak? So the importance of the voice is because we convey emotion. So once you convey the emotion with which you are connecting with the people. So it's all about the emotion. Maybe it is kind of a pleasing, or maybe it is a laughing. You will be using the voice along with the facial expression. And many times we shout or we scream. That is also a emotion. So we try to convey our emotion and we are trying to interact with the particular environment. So even though when you are trying to be emotional, you will be using the voice. And in fact, many times your teachers do this, right? Yes. So our parents do this. So whenever they say something, we're all like scared, right? So they are also influencing the environment. They're also influencing the people. So the voice has a power to convey emotion, to influence or to interact, and to have that human interaction to level up. So it has so much of the function associated with that. So we may say like, why are you yelling at me? Why are you shouting at me? Every time you will be keep on shouting at me. But ultimately they say it is all the voice and the communication. Sorry for yelling, but I'm very serious. So I just want to convey the point, what I am just trying to convey. So it is all about voice, emotion, and it's all about the communication. So this is all important. And ultimately we have the voice disorders. So here what happens, a person is just saying like, can you please come here? We may think like, why are you angry on me? He is not angry. He has some voice problem. So he's trying to say, come here, right? So this, he is not shouting at you. So once a person has a voice problem, he may not be able to convey this particular emotion, or he may not be able to convey the communication, will not happen in the right way. So this is an area where ENTs and speech pathologists or the voice coaches come into the picture, ultimately to build up that voice and emotion, communication, interaction to be not be again to bring it back, so which has got disturbed. So many times whenever we try to scream or yell or we try to laugh, so many of these times unknowingly our voice will be going into an abuse or the misuse state. So once the voice goes into the abuse or the misuse state, so definitely there will be a muscular imbalance. So this muscle has a particular dynamics. It has a boundaries, which we call it to be the biological aspects to it. If that crosses, then definitely it will be having a particular voice problem will actually arise. Apart from that, we have some of the neurological conditions like the vocal cord paralysis, spasmodic dysphonia, or the voice tremors, and some of the growths. So which will be also contributing into the voice problems. So as you can see, here is a cyst, and this is a carcinoma, and this is a polyp you have in between this vocal cord, and these are the nodules, which is mostly due to the abuse and the misuse. But this carcinomas and all is again might be secondary to, may not be exactly due to the misuse and abuse, but it will be secondary to the body nature where that may develop into a tumor. So we will be trying to look into the what is the cause of this having a voice problem. As you know that the morning sir also mentioned that we have so many etiologies of the voice disorders. We can make it like the functional and the neurological and this particular organic. So we have so many medical conditions or this particular causes which will be leading to the voice. So right. Okay, so we will come back to this again. So now, so let's just try to understand what is the normal and the abnormal voice. So as sir has explained beautifully with the demonstrations, so we will just try to see what is this normal and the abnormal voice. I will be producing few voices, okay, and I want you to say N or A. N means normal, A means abnormal. So let's see. Abnormal, okay. So if I tell you I am singing, if I tell you now I am going to sing, and then if I say so this normal, abnormal may be also related to the context or the particular task. If I am speaking, if I just increase my loudness, increase my pitch to a great extent, then we don't hear so often a person speaking at this particular pitch, right? So that our brain will immediately say this is not we hear every day. So we term this to be an abnormal. But if I tell you I am going to sing, then this high pitch you may not be considered. But if I continue my singing, then you will say he is a very bad singer. Right? So yeah. So our abilities to say whether it is normal, abnormal is also depends upon the context, and it also depends upon the other parameters like the pitch. Right? Now I will be demonstrating another tone. Make it loud. Yeah. Right. So if I have to say numbers, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes. Right, right. So this is an abnormal voice, right? So now here there is some disturbance in few parameters, like the pitch, as I've just mentioned you earlier. If the pitch is not to the particular age or to the gender, we have a boundaries. So if that is not with that, then we will be calling it to be a abnormal in the pitch. And also we have something called the loudness. If I am speaking like this, my name is Panida Reddy. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Is it a normal or abnormal? Abnormal, right? So rather than abnormal, you have before saying it to be an abnormal, you have to ask me to increase the loudness, right? If I am not able to increase the loudness, then you may consider it to be a abnormal. So you cannot just judge by taking one piece of the information. You should be able to cross check it with here and there. So you should also give me little more task. And the quality of the voice is more or less the this adduction of the vocal cords. So we'll be having a breathy voice or we'll be having a harsh voice. Now I will be demonstrating one voice. I want you to tell whether it is a breathy, harsh or hoarse. Okay? Hoarse. Hoarse. Now we are all getting confused whether it is high pitch or it is an harsh voice. High pitch. Now, it is a harsh, right? It is a glottal fry, right? Which is also having a more adduction of the vocal cords, which will be giving you a disturbances in the voice. What is this now? Harsh voice, which is a significant harsh component, again with a breathy component also added. So the air is also leaking. So the hoarse is nothing but combination of harsh and also the breathy component. And also we have the resonance, right? Now I will be speaking a particular tone and I want you to guess what it is all about. 1, 3, 4. Sorry. So it is moreover a nasal, which we also call it to be a hypernasality. So there is a more nasal to it. So it is the pitch, loudness, quality and the resonance where we need to go according to the particular age and the gender, and we try to correlate it with the particular person who had come to us. So muscles I'm not going to in detail because sir has already discussed about it. So, and also whether to say it is normal or abnormal, we also consider the discomfort and the trouble in talking and the voice fatigue leading to the change in the voice, and the reduced voice endurance, frequent need to clear the throat, and the reduced social interaction due to the voice problem. So these are all the aspects we need to consider to term this to be a abnormal voice. So now, whenever you do a voice assessment, so you will be going not directly to do a VHI or to directly to do an acoustic analysis, right? As soon as the patient comes, you will be interacting with the patient. You will be speaking to the patient. You will be asking him what it is, the problem what they have. So whenever they are speaking to you, your ears should start working and try to analyze how is their pitch, what they are speaking. How is their loudness? How is the voice quality? So, because as a patient comes in, initially 4 or 5 minutes he will be talking a lot, right? As soon as you ask what is your problem or where do you live, he will be speaking a lot. So that initial 4 to 5 minutes is his own spontaneous way of conversing to us, right? So that is very, very crucial for us to hear, and we have to hear by demarcating the pitch. How is the pitch? How is the loudness? How is the quality? How is the resonance? Because the other task like this particular MPD or the SASA ratio, where we instruct them, right? We tell them, now you have to continue saying for the 10 seconds, 15 seconds, and we demonstrate them, right? Many of the times when you make the patient to say MPD, he will be saying in the same way how you are pronouncing it. If you say it in the high pitch, he will also start saying in the high pitch. And many times we don't realize how we are demonstrating to a patient. So it is also very, very crucial that you should record your own voice. So how do you say ah? Then only you should demonstrate that correct optimal, your own optimal voice to him, so with which he will be able to demonstrate the same voice back. So this MPD and SASA ratios and and counting the numbers, whatever we ask them to demonstrate. So there will be a slight variation factor. So it is very important to listen to their voice when they come to us. And of course, how do you differentiate abnormal singing? Maybe madam can tell us a few points, ma'am. Ma'am, how do you say he is a very good singer or he is a bad singer?
There are few factors involved.
Right.
One is pitching,
Hmm.
especially in
Non-singable voice.
and number two is the ఒకటే చాలు.
Sure, sure. So, in my perspective, I may put it in this way: like you have the so many pitch notes, right? If I try to vary my pitch, oh, this is a low pitch. Maybe around somewhere around, how would be my hertz? Oh,
70, 65.
yeah, 80, 90, close to that. Yeah. Maybe close to that. So, whereas if we ask madam to do this variation, she will be going by touching most of the frequencies like 80, 90, 100, 110, 120, 130. So she will be going in varying the pitch with all. But what I did is like 80, 120, 160, 220 and 280 or so as a singer they have the capacity to touch most of the frequencies whatever you ask, but as a untrained singer, so we may not be able to touch each and every frequency. So my range is like very limited. I may go to 80 to 230 or 260 up to some extent, but in between I may miss so many pitch notes. So because I have not trained myself in the singing. So that is the only difference. And also yes, endurance power, how much is the loudness you are able to vary. So that these are all the factors we'll be also considering. So according to Pratt and Swift, so to suggest that assessment should fulfill these three criteria. It should offer a detailed description of the patient's vocal characteristics and how they vary over time. It should determine how severe the disorder is. Your voice assessment should give these three answers at the end. Alright? How much is the severity and how much is the and what are the characteristics, and it should determine whether the patient will benefit from the therapy or not. This is the ultimate thing. If the patient is not, you are not able to say whether he will benefit from the therapy or not, your assessment is not yet done. Okay. So these are the three factors what we do. And in this voice protocol, mostly we follow preliminary information from the case history. So we try to ask the questions to them and we hear perceptually how is their voice, how is their pitch and loudness. And then we try to do some acoustic and aerodynamic measurements like the sir demonstrated. And then we try to visualize the larynx. And we try to look into the larynx, how the vocal cord is moving. So, and we have the few tests, like we have GRBAS, which is nothing but it is a perceptual scale where we try to rate depending upon 0, 1, 2 and 3. So we do endoscopic evaluation of the voice where we try to visualize the voice and we will see how is this vocal cord is exactly moving. So this is a rigid endoscope where we will try to go through the oral cavity and try to visualize the vocal cord movements. We also have the fiber optic endoscope where it will be passing to the nose and we will be trying to see the vocal cord movements. So are you interested to see some endoscopic videos? Yeah. I'm not able to figure it out. I'm not able to figure it out whether they want to see or don't want to see. What is this? Vocal cords. And these are? Hmm? Adenoids. Yeah. Right. So here you can see this vocal cord little more clearly, right? So this is a typical, so this is a normal vocal cords or abnormal vocal cords?
ఇంకొకసారి ప్లే చేయండి.
Yeah.
Abnormal, right? Because there is no closure of the.
One second, one second. Yeah. You can only see the movements of the vocal cord when we ask the patient to talk. If I have not instructed the patient to talk, then you will see only the breathing patterns. So these vocal cords will be open only. So let's try to play some other video. Chicken ఒకసారి. Good. How is his voice? Try to see more of this area. Yeah, strain voice. So what is the movement you are seeing here? Try to see more of this area. Come back. Try to chicken ఒకసారి. So what is this movement you are seeing here? It is a soft palate movement. That is VPI, velopharyngeal movement. That what we see. These are all the lateral walls, and this is the palate. So this is the soft palate. So once we try to enter inside, try to see more of this area. And back. Now try to see more of this. Yes. You see? Yes. Good. Yes. Yes. చిన్నగా మింగండి ఒకసారి ఒక నిమిషం సో యూ కెన్ గుడ్ ఇంకొకసారి 1 second let me just focus. Yeah, so this is his epiglottis. Okay, here he is having an edematous epiglottis. He is a patient of post radiation because of the CA, supraglottic CA. They have he had the cancer in the supraglottic area. So for that he has undergone the radiation therapy. This has been almost 3 months post that. So still there is slight edema, but it was previously it was more. Now it is less. And because of this edematous, we are not so we need to little bit do some adventures to go from the front. We're not able to see the vocal cords as easily. When you swallow this stuff, you have to come just try to now go a little more closer. Yeah, there is slight pulling of saliva. As you can see, these are the arytenoids, right? These are the arytenoids which are also edematous. And here you can see the vocal cords which are very, very deep. And here you are not able to see the space how you saw in the previous video. That much space is not there. And because of that, there is also slight paresis on the one side. Because of that, his voice is very, very strained voice. Very, very strained voice because there is not proper adduction of the vocal cords. Vocal cords are not adducting, and is using this arytenoid muscles also to go as a compensatory mechanism. So this is also an MDT, muscle tension dysphonia. చిన్నగా ఈ ha. As you can see, still there is a gap. So and here airway is also compromised. There is not enough space for the particular air to inhale and this exhale. So yeah, so this is a patient where I have done the scopy, and we have just tried to understand how is the patient. So why is this patient having a strained voice? See, many times whenever the patient comes to us, we will just try to hear their voice and we will say whether it is in high pitch or strain voice. But inside, if you have to finish this particular voice assessment, we have to go inside the vocal cord and check what is really happening with the anatomy and the physiology of the larynx, so with which we can come to a conclusion. This patient is also, as the airway is very much compromised, right? So anybody can guess is the patient is on the tracheostomy or not? How many of you know what is a tracheostomy? Sorry? Tracheostomy, not laryngectomy. Laryngectomy is removal of the larynx. Tracheostomy is there is a small stoma and they will be putting a small tube with which the patient will be inhaling and exhaling. Okay, so this patient was with the tracheostomy tube, and we had tried to improve his particular breathing and swallowing up to some extent, and also the voice, and then finally we have removed the tracheostomy of this particular patient. Now let's see another larynx where we can get an opportunity to learn few other things. One second, I need to figure it out. Where is the exact thing? So what is this? Anybody has any idea? Tube, yes. This is the Ryle's tube, which is actually coiled in the laryngeal structure. So here it has been just traveling from there to here, round it up. So we may have to remove the tube and try to check. So now you can visualize the vocal cords.
Why was it not possible to reach the vocal cords of the previous patient who was under the
Yeah, because there was a airway is very much compromised, right?
tube is not able to travel inside?
No. We can go a little bit, but the patient will be coughing because our scopy will be touching that particular tissue, and but still we got the information. So we will not go beyond the vocal cords. We will only go till the vocal cords and check. If you have to go beyond the vocal cords, you have to give more anesthesia, and you have to do a bronchoscopy from the mouth. So what we do, it is a very shortened tube. It will not be able to reach beyond that. So here you can see, one second, let me just identify that right, which I can show it to you. So this is all pooling of the, right. Now you can see this vocal cord. Everything is, the saliva is pooled here. He will be talking in the breathy voice, okay? So he has been talking in the breathy voice, and he many times he just keep on coughing. Here we could see this, both the vocal cords are not able to open. Okay, so both the vocal cords will be able to see. Now the saliva is entering into the below this vocal cord area, so that is the reason he keeps on coughing. But at the same time, he is not able to open the vocal cords more widely to generate a sound. So this is bilateral vocal cord palsy, where the vocal cords are not able to open. Opening means what? Abduction or adduction? Abduction. So this is bilateral abductor vocal cord palsy. They're not able to abduct. So this patient has a medullary infarct. So because of that, he has developed this swallowing issues also he has, because all the saliva is going into the airway. So he is not able to generate the voice also. So this is one kind of, so what I am just trying to say with this particular video says, to hear and to perceptually feel, it will not be able to correlate with the physiology. So this voice assessment will be only getting completed once you hear and do some acoustic analysis and also visualize the vocal cords. So yeah, so we will be taking help of ENTs where we try to do the scopy, or nowadays the SLPs are also getting trained to do the scopies like how I do. What are all the videos you saw, I do it in my clinic with some of the precautions what we take. And this is definitely an advanced level of the training, but yes. So because my assumption is if I handle the scope, if I do it, I can look for what all the aspects I want. Many times we do it this for 20 minutes. We put the scope inside for 20 minutes. In fact, we also try to use a therapeutic strategy and try to check how is the vocal cord is moving with this therapeutic strategy. Like for example, we have so many voice therapy techniques. So which technique is working for this particular patient? So many times, if a patient's voice is like this, okay, so this is completely a breathy voice. So well, you will be able to get any number in the acoustic is if the dysphonia is very severe, if there is no periodicity in the signal, you will not get anything in the acoustic analysis. But whereas in this particular visualization of the vocal cord, you can visualize the vocal cord. If the vocal cord is not moving, we could definitely able to tell why it is not moving. Okay. So finally, I will show you one more, and then we will just proceed for the other. So he had some adenoids hypertrophy, if I'm not wrong, doctor. Yeah. But that is not our concern as such. So this is a soft palate, and we are going beyond this. So now you have to tell me how is his vocal cords are moving. Just give me a second. I will pause. How is his vocal cords are moving? Can you see his vocal cords? Yes? How many say yes?
Just a complement of our doubt.
Yeah. Incock, sir. Do you feel this is the vocal cords? Yes? How many people say yes? Raise their hands. So these are all the false vocal cords. This is not true vocal cord. Okay? So he is having a type 4 muscle tension dysphonia. So where his false vocal cord is also moving, as you can see. Now I will show you what is his true vocal cords. So this is all the false vocal cord, right? So beneath the false vocal cord, there is a true vocal cord, and I will just show it to you. So here, right? Here, so here is the true vocal cord, but this true vocal cord is also not very much prominent. We could see. We are suspecting it to be the sulcus vocalis, and he has been habituated to use only the false vocal cord. So now, yeah. So we have been working upon to trigger this true vocal cord movement up to some extent, and he is refusing for the surgeries to go. But yeah, so this was the initial list. So this is not the vocal cord. So for this patient, for this particular person, when he speaks, it is moreover like a completely a breathy and this harsh component, which is a combination of which is nothing but the hoarse voice, a severe hoarse voice. He will be mostly speaking like this, right? Where there is a lot of disturbance in the voice. There is also a kind of the diplophonic voice. So whenever he talks. So this is all because of the false vocal cord movement what he's having. So if we don't link the perceptual analysis with the visualization, we may not be able to understand the complete picture and how do we have to help for this particular patient. Right. So now we'll just go through a few things. Like you can just Google it asha.org, where you have a practice portal for the voice disorders. So where you can just see the how do you assess the screening of the voice, and you have a comprehensive assessment of the voice where we try to do a lot of test, and ultimately we will be going ahead with the case history and the self-assessment. Self-assessment is we mostly use a VHI where they will be have to rate it. Apart from that, we do oroperipheral examination. And as sir explained in the afternoon about the respiration assessment, we'll be doing the respiratory pattern, how is their breathing, and then we do coordination of the respiration and the phonation, breath hold pattern, how does the sir explain to us, and we do maximum phonation duration and the SASA ratio, and also auditory perceptual assessment. And the voice quality, yes, whether it is a roughness or breathiness, strain, and a pitch, how is the pitch, and additional things like the diplophonia, aphonia, and the pitch instability. So these are the things we will be able to rate it. Apart from that, we also looking into the resonance and the phonation. And apart from this, we have few other things like the instrumental, which is the laryngeal imaging, and we do acoustic analysis. You can just go through this. You will try to understand what all the protocol it's all about. And apart from that, there are two different voice. So as you know, every clinic uses a different voice proformas. As Helen Keller has a different voice proforma, Ma also has a different voice proforma. So we may just go into the few of the voice proformas where you will understand like what are all the parameters they will be looking in more detail. So I just want to highlight few things here. That is the, one second. Yeah. So this is something called the voice handicapped index, where all of you must be aware of the voice handicapped index, which is a shorter version, which has only the 10 parameters. So depending upon that, we will be making them to understand whether how much they're concerned about the voice. And we have the singing voice handicapped index, where we talk more about the singing aspects into it. Like we can have a, it takes a lot of effort to sing. I'm unsure of what will come out when I sing, whether I will be able to go to the right note or not. My voice gives out on me while I sing. My singing voice upsets me. So these are all the questions related to the singing parameter rather than the speaking. So depending upon the severity, we'll try to understand their singing voice. So these are the differences for that. I can definitely share these documents with the organizers. You can take it from them. And this is the reflux symptom index, where we try to understand how much is the reflux that GI reflux is contributing to the voice. So coughing after you ate or lying down. So breathing difficulty or episodes, troublesome or annoying coughs, and the sensation of something sticky in your throat. So these are all the indicative of the active reflux, which can also contribute to the voice. And this is a glottal function index, where we try to understand the glottal, how much you are putting an effort at your glottic area, whether you're doing a lot of the glottal fry or glottal fatigue or not. So these are all we can integrate into our assessment tools, and whenever you try to do this. And this is vocal fatigue index, so where we try to understand in general vocal fatigue, how much of the voice you're using it and how much you're getting tired of using your voice. So you can just go through about all these things along with the perceptual assessment and also the visualization of the vocal cord. And here is one more voice assessment proforma, where we'll try to share it, where here we try to understand the vocal hygiene, how much is the hygiene. So this is all taken from the ASHA, American Speech and Hearing Association. And we also go into detail of vocal activities, how much is the activity you do how many hours you will do per day, and the environmental issues and the reflex history and the vocal performance. So this is all, now you will be feeling more of a sleep, but yes, so you can just definitely go through into this performance to actually understand the more of the perceptual and other kind of the assessment tools what we can use here. So with this, I come to an end of my talk. So yeah, now we can open up for the discussion. There is no end of the discussion when I just threaten you, right? If I say that's it, okay, then leave, then there is no end of the, there is no point to have a discussion. Yeah, please. Anybody has any questions? Speaking wise, I'm good, but I only have problem with the singing, and I am a professional voice user. When they say like that, then we will also try to see. But the reality is, whoever says I, so in the talk also they may not be using the right this thing. They may have a type 1 muscle tension dysphonia or the type 1 to type 2 muscle tension dysphonia also.
I just
So
have two questions.
please.
In order to
Almost never, sometimes, and this is always. So depending upon this 10 questions, if the 5 questions are fall under 3 or 4, so that means you have a major, you know that you are, we get only the 0 and 1. That is indicative of you are not aware, or you don't feel that you have any you have any concern with the with the singing. That doesn't mean that you don't have a problem at all. Right? So this is just the perceptual rating of your own voice. Generally this we will give it to them, and they have to rate this thing of their self ratings things. So this we try to understand how much they are concerned, like, and we try to do a scopy and try to see how much is their voice. And when we do scopy, we also ask them to sing or go to the notes, and we try to check how much is the variations are happening. If it is required, we may also do a stroboscopy to analyze little more of the mucosal wave amplitude in more detail. So we will try to combine both the things and try to tell, because sometimes like they may be having a so much worry about their voice when they are, yeah, anxiety. In that they may rate everything to be 3 4. So that doesn't in that scenario we try to hear their singing and tell them, you feel you have a problem of 3 and 4, but for me to hear, I am definitely able to appreciate it. I feel you have a problem of 0 or 1 only. So sometimes we may have to give them the right feedback, because they may not be getting the right feedback as well.
because this second point,
Right.
Question to you, answer from him. Question to you, you answer. Then sir will, like, because he has seen the case, he would be in a position to do it. So based on what I talked only, I am asking you this question. Huh? Why?
what was the answer?
Thickness of the structures. Yeah, so when you expect, see, you don't have a endoscopy. The person comes and speaks to you in a low pitched voice. What do you expect could be inside? Mass or something thickening. That you consolidate by the endoscopy. Fanidhar, is that right?
Yes, sir.
So you have to bridge up the whole systems. Then you go for whether it can be removed by surgery, it is carcinoma, or edema, you give some rest, and management strategies, I think Jish will take care.
Mechanism followed by
Yes, yes, yes. Only for that purpose. Right, thank you.
Yes, sir. As sir said, for this particular patient, because of this particular edema, it was supposed to be the low pitch, right? But what they do is they try to put more of the pressure, where they try to make it like a muscle tension dysphonia, and they try to squeeze it more. So with which automatically the pitch also increases a bit. And here this vocal cord movements are also not approximating in a right way. They're still not able to close. So there is a breathy component to it. And whenever they try to strain it, they will be having a slightly high pitch kind of a tone. So now, as sir mentioned, we need to make two things. One is like main problem, another is like a contributing problem. Right? Many times we see a unilateral vocal cord palsy, they will be having a breathy voice. My name is. So if it is a unilateral vocal cord palsy, they have a breathy voice, but they try to be little bit more louder. Right? When they try to make it louder, they will squeeze everything. They may end up speaking like this. Right? they are speaking like this. Now there is some voice, right? This voice is because of the false vocal cord, not because of the true vocal cord, right? So here it is a secondary muscle tension dysphonia. So nowadays it is becoming little tricky for every clinician to only come to a conclusion by only hearing the voice. So that's how we try to hear definitely and come with an particular hypothesis and correlate it with acoustic analysis. But if the voice is very, very severely breathy, acoustic you may not get any of the information, right? Then you may have to go to a visualization of the vocal cords and try to correlate the voice and the visualization of the vocal cords. So that's how where we try to link it. Right. Any other things? Yeah, there is some